Good afternoon. Thank you all for joining us today. All right, so I'll give it a couple moments. We'll do some introductions. All right, welcome to our Baptist Behavioral Health Grand Rounds. We'd like to thank you for joining us today. I'm Dr. Francesca Varallo-Sims, Director of Education and Training for Baptist and Wilson Children's Behavioral Health. Before we begin, just a few notes on today's presentation. If you have any questions, please do submit these into the Q&A box. At this time, if you would sign into the chat with your name, especially if you joined by phone. So if you would, please help me in welcoming our speaker today, Dr. Savitha Putaya. Dr. Putaya is a board-certified psychiatrist, fellow of the American Psychiatric Association, and Baptist Behavioral Health's own medical director and attending physician. She completed her residencies at Drexel University and Johns Hopkins Hospital. In her current role, she offers direct oversight for our department's inpatient and outpatient psychiatrists. Dr. Putaya also provides coverage in the adult psychiatric unit and consult service line for Baptist Health hospitals. There's several of them, as you all know, freestanding EDs as well. She has been essential to the development of the treatment-resistant depression clinic, in which she offers ECT, esketamine, and long-acting injectables. Dr. Putaya supports our department's clinical training efforts as well through teaching local medical students, psychiatry residents, developing collaborative relationships with universities, in addition to her leadership role in the Psychiatric APRN Fellowship. Finally, Dr. Putaya serves in an administrative capacity on various hospital committees and is the physician champion of this Behavioral Health Grand Rounds. Welcome, Dr. Putaya.
Thank you so much. I appreciate it. Thank you for the kind words. Are we going to wait for a couple seconds, or, are we ready to?
Yeah, we can just forge on. Whenever you're ready, I'll advance the slides.
Okay, great. Yeah, I'm ready. If it's 12:02, I think that we have a lot of material to go over. So I would say we can get started. Thank you. Okay. So Dr. Sims.
Mm-hmm.
Yeah, I don't see the slides.
Okay.
Give me.
Let's see. Oh.
Here we are.
Okay, do you see me? My Zoom's acting up a bit.
Yeah.
I can see your slides.
Okay.
Oh, no. Don't.
All right. Sorry about that. Yeah, so yesterday I was having this issue as well while Dr. Andrews and I were on a call. So in the meantime, Dr. Andrews, if I could send the PowerPoint to you as well, if mine continues to stop, I think it's some type of bandwidth issue. So I'll get the slides back up, and Dr. Putaya, let me know if you can see them, okay?
Yes. Yeah, I can see you, Yes.
Mm-hmm.
Okay, there we go. Okay,
Great.
much better. Okay, great. So thank you everyone for joining me this afternoon. I just want to go over a topic that is frequently encountered on a day-to-day basis. And the fact that so many of you are joining me today is a testament that you have either encountered clinical depression personally, either as a healthcare professional or as a family or, a loved one who's going through. So I do want to review this over the next hour. I want to take the time to review the concept of treatment-resistant depression, and also review the different treatment options available in general, and talk to the options available within the Baptist health system. Next slide. Okay, so I want to start off by saying stating the obvious. The depression is common, it's recurrent, and it's chronic. So when we think about the prevalence of depression, it's about 10%. So 1 in every 10 people that you meet has a diagnosis of clinical depression. And if you talk to any psychiatrist, the common census is going to be the prevalence is a lot higher. But because of the stigma associated with depression, there is a lot of underreporting. I think it's as common or more common than hypertension, which is about 47% or so. So it is recurrent. And just given the nature of clinical depression, it adds to the global disability. And, if you have persistent and severe depression, one of the fears is that it would lead to severe hopelessness, feeling of just being trapped, and suicidal thoughts and suicide attempt and a completed suicide, which is very common which is one of the most feared outcomes in the young adult population. So this is very disabling. It's very concerning. And what is even more concerning is that with the current treatment options that we have, only about 20 to 40% of the patients do not show any sort of do not respond adequately to the repeated trials of antidepressant medications. Next slide. Okay, so I want to start off by defining the concept of treatment-resistant depression. So anytime I see a patient with clinical depression, we want to be thinking about what is this major depressive episode a part of? Is it a part of a recurrent major depressive disorder, or is it a part of bipolar depression where a patient can have oscillations in their mood? They can have both poles of the mood. So we want to define the episode accurately, so that way we can, because it has treatment implications. If you define someone has bipolar depression, the treatment algorithms and approaches would be very different. So we start from the very top by identifying the correct diagnosis. Next slide. And once you identify that the patient has, say, recurrent major depression, you want to know, okay, what are the treatments has this patient been through? And when we talk about treatment resistance, what is the number of trials of treatment that the patient should have had to qualify as treatment resistance? Is it 1, 2, or more? There is a large variation if you look at the papers, but what is evident is that once you've had 2 adequate treatment trials, the chances that you would respond to the third one drop precipitously. So that would be the magic number. If you have had 2 adequate treatment trials that have not worked, your symptoms have not reduced, then that would qualify for treatment resistance. Next slide. Okay, so a couple of other important concepts that we always have to bear in mind. What is an adequate trial? When I say adequate trial, we're referring to, are you on the minimum adequate dose that you ought to be on for this particular episode? And 2, have you taken the medication for an adequate duration of time? So you have to meet criteria for both. If you are taking the medication at the correct dose for the correct period of time. And what is the end point? The end point is either response or remission. When I say response, there is at least a greater than 50% or more reduction in the severity of symptoms. And remission, obviously, is the golden goal, where you don't have any symptoms at all. So these are some important concepts to keep in the back of your mind. Response, remission, duration, and dose. Next slide. Okay, so just kind of combining all the concepts, some of the concepts that I've just introduced. So if you have had, if you meet criteria for a major depressive episode, which is either a part of unipolar depression or bipolar depression. And if you have not responded, as in if you have not had greater than 50% or more reduction in the severity of your symptoms, and this is despite 2 or more adequate trials of medications where you're taking an adequate minimum dose for at least 6 weeks or more at the therapeutic dose, then you would qualify for treatment resistance. And one important thing to keep in mind is that all psychiatric medications take at least 4 to 6 weeks to begin to show efficacy. So we're talking about, and most medications, there is a dose titration. So we start with a minimum dose, and depending on how you tolerate, we move up to the treating dose. Next slide. Okay, so anytime we, we think about treatment-resistant depression, one of the landmark trials, which really helps a practicing clinical psychiatrist or any mental health professional, is the STAR-D trial. The STAR-D refers to the sequenced treatment alternatives to relieve depression. So essentially, this was a large prospective clinical trial, which was conducted nationwide, which involved about 14 university-based hospitals. And it involved about 23 psychiatric clinics and 18 primary care clinics. Next slide. So the STAR-D trial was a landmark study because it really helped us understand how are we doing with our treatments, how are we helping our patients. So if you look at the right half of this slide, you'll see that there is a decreasing trend. So after the first antidepressant, about 28%, a third of the patients respond. And out of the 2/3 that don't, you have another quarter of that population responding after the second antidepressant medication or the intervention. And after the third, you'll see that only about 16, and after the fourth, you only have about 7% of patients responding. And if you look at the left hand of the slide, you'll find that with every antidepressant or with every intervention that you have, the risk of adverse effects escalates. So if you have a loved one who has depression, after about 2, you'll see that every medication that you're prescribing has more and more side effects, has less and less efficacy, then that is not a good scenario. Then it just means that the person is continuing to suffer. Next slide. So what is really important to, the few things that were highlighted by the STAR-D trial, that you have to be patient. You have to wait for at least 14 weeks, at least for about 3 months or more, to be on a good dose of the medication. Of course, this is barring that you don't have any side effects from it, for you to see any kind of major side effects. And it also highlighted that positive outcomes decrease precipitously after the second intervention. And what was, there are many take-home points, but what was also seen was if you have remission where you have no symptoms after an intervention, then the chances that you would continue to do well after a year were much higher than if you were a responder where you just had over 50 or more % reduction in the symptoms. Next slide. Okay, so over the next the course of the slides, I want to talk to you about the different interventions available as alternatives to pharmacotherapy and psychotherapy. And the first one that I would like to talk about is TMS, that stands for transmagnetic stimulation. This is a form of therapy. This is a treatment modality that was FDA approved in 2008. And what is advised is that along with your TMS therapy, you have to continue your concomitant medications, your pharmacotherapy. And next slide, please. So just want to introduce, want to talk about how TMS works. It's essentially focused, it's basically a large electromagnet that is able to create a magnetic field, which then sends out electric impulses and stimulates the areas that control the mood and emotions. Next slide, please. Okay, so one of the ways that we would think about is that, there is direct stimulation of the brain. We want to think about the brain as an electrochemical device. And by means of TMS, you have rapid magnetic pulses that are inducing electrical activity that turns the neurons on, that helps in regulating the that helps in regulating the balance and helping the nerve cells fire together. And there've been many other beneficial things noticed as well, where it enhances protein synthesis and just kind of there's an upregulation of the brain neuronal activity. Next paragraph, next slide, please. What it, one of the regions, when we look at TMS, we're particularly positioning the magnet over one part of the brain, which is the left dorsolateral prefrontal cortex, especially in major depression. What we have seen is that the TMS can be beneficial for other conditions, such as OCD and chronic pain and smoking. But when we're talking about major depression, this is the area that we're looking at. So having concentrated electric impulses, magnetic impulses in this particular field, on this particular area can be very beneficial in relieving depression. Next slide, please. What I want you to think about is you're essentially activating a brake. So think about there is like chaos in the brain when you have depression or when you have unregulated moods, and the TMS is just going to bring some sense back and to restore some rhythm. And in terms of efficacy, about 50 to 60% of patients who, if you have had 2 or more antidepressant medication trials, you've not responded to any kind of treatment, and you're tired of having side effects, then TMS would definitely be a treatment option for you to consider. And what's also seen that these patients experience full remission, and we talked about earlier, means that the symptoms go away completely. Next slide, please. Okay, these are some trials that talk about the effectiveness of TMS that kind of have been replicated. Again, we see that there is a large difference between patients who receive treatment versus placebo, and it is highly effective. Next paragraph, next slide, please. Okay, so when would you consider TMS? If you have had, if your antidepressants have not worked, if you have a lot of side effects, then that would be, then TMS should definitely be considered. At Baptist, we are thinking about coming up with the option of TMS for OCD as well, which is a new FDA-approved indication. So that is something that we would be exploring this coming year. And when we talk about any treatment, we have to review side effects. The most common side effects that patients complain about is discomfort, pain, headaches. And the most serious side effect that one would need to know about TMS is the risk of seizures. When we talk about seizures, the percentage they're talking about is less than 0.01. So if you have a past history of seizures, if you have any history of traumatic brain injury or bleeding in the brain or an eating disorder, which would impact your electrolyte imbalance, then that is something that we would have to carefully consider before approving for TMS. And if you have any metal within about 30 inches from the left part of your brain, then that would also be a contraindication because of the magnetic activity, you can have burns. Next paragraph, please. Next slide, please. Okay, so again, reiterating, if you have any sort of, the contraindications are if you have a personal history of seizures or epilepsy, if you have any kind of implants in the central nervous system, cochlear implants, deep brain stimulator, those would be contraindications for TMS. And we can, if they are at a distance, when it involves cardiac pacemakers or defibrillators or vagal nerve stimulants, we have to be ultra cautious, but that would also be something that we have to be very careful about. Next slide, please. Okay, and how long are the TMS treatments for? So the treatments are, they last for about 6 weeks. It's Monday through Friday. So it's a total of about 36 treatments or so. You can have 3 weeks of additional weeks weaning off the treatment, but typically it's just a block of 6 weeks of treatment. And most patients, respond favorably, especially if you have stayed on pharmacotherapy and continuing psychotherapy. And at this point in time, the insurance companies do not cover maintenance treatment, and we do not offer that at Baptist. If there is a strong case for maintenance treatment, and if a patient is opting to, if there is like a history of TMS treatments, repeated TMS treatments, and there's failure as soon as you withdraw within a few months, then we can consider some sort of a taper, but at this time we are not offering tapers. There are patients who come back after 3 to 6 months of the initial TMS treatment, but what is often encountered in clinical practice is that typically they stay in remission where they have full resolution of all their symptoms for at least a year or more. Next slide, please. So I want to quickly talk about TMS for bipolar depression. Unfortunately, there is no FDA indication for bipolar depression, although there are many centers that you would find who would consider for that indication, but at this point, it's not FDA approved. Okay, next slide, please. So just a few pointers as to factors that may predict a better outcome response to TMS. So if you have had fewer antidepressant trials prior to trying TMS, if you have lower levels of anxiety, there's no psychosis where you do not have delusions or hallucinations. And if you are seeing for a TMS consult early on in your depression and not where it's not prolonged or it's gone on for too long, if you do have sleep disturbance, and it's also seen that TMS responds, better in the younger population, but again, this is not replicated in other studies. But so younger or older patients, if you with sleep disturbances, lower levels of anxiety, purely mostly depression seen early on, lesser number of antidepressant trials are all great responders to TMS treatment. Next slide, please. Okay, so but what we have also seen is, I just had a patient where even if you have significant comorbid anxiety, you're still a good responder. You can be a really good responder to TMS. But we would opt for ECT if you have any kind of psychosis where you have hallucinations or delusions, if you have acute social delusion. Next slide, please. Okay, so that was a very, very quick and brief overview of TMS. And I want to talk about the next treatment option, which is ECT. So ECT stands for electroconvulsive therapy. Lots of negative portrayal in the media, but it is the most effective treatment option that there is for a depressive episode. And I want to start off by talking about the most common scenarios that we do consider ECT. So if the older you are, the more likely that you would respond to ECT treatment. The more severe of an illness you have, the more of a response to ECT that you would have. And if you have catatonia, which is this extreme psychomotor condition where you are rigid, mute, you haven't eaten for days, you're just in bed, you have five, all the other medical conditions have been ruled out, then there is a very high likely chance, it's the golden standard for such depressive, serious depression. If you have presence of psychotic symptoms, then ECT would be the way to go. Next slide, please. And if you have had prolonged suffering, you have, and you need a rapid recovery, ECT, which is almost like, cuts the initial treatment duration to TMS by half, because at least about 3 ECTs per week, averaging. And with the average number required to get out of such a deep depression is about 6 to 12 treatments, then it is then it is something that would help you achieve faster recovery. And also, if you have grave suicidal symptoms and you really have melancholic depression, whereas persistent, severe lack of sleep, poor sleep, disturbances in your appetite, just an overall sense of dull and gloom, then that would be a case for ECT. Next slide, please. Okay. Again, it is indicated for treatment-resistant depression, as we defined earlier. If you have comorbid medical conditions, then where your antidepressant is contraindicated, so if you have hepatic failure, liver failure, you cannot take antidepressant medications, then ECT would be bypass all of that and would be able to help you with your severe depression. And if you have past history of responding to ECT, or if there is a patient preference, then there is a very high likelihood that you would respond again. Next slide, please. Okay. Again, you have, look at the different treatment options, the longer the duration of just anything in medicine, the longer you've had the illness, then obviously the chances, this rates of 8% go down to 50, but still greater compared for that particular patient who's had many trials, and is used for if you have comorbid illnesses. There are other things that would prevent you from recovering, from your depressive episode, and that would also decrease the likelihood of response. And just to reiterate, if you have post-stroke depression, catatonia, and those would all be increased ECT responders. What we do find is that there's a lot of personality disorder present with treatment-resistant depression. So we find that that is a very common reason for patients not responding as well. Next paragraph, next slide, please. Okay, this is just an illustration of ECT. The concept is, again, this very small electric pulse that is passed through the brain. And what it is like, I think it as
Hey, Dr. Pataya.
Neurotransmitter.
I apologize. Yeah. It's really difficult to hear. Can maybe just move your phone a little bit or maybe turn off your video? That may help. I'm so sorry to interrupt.
Yeah, sure. Thank you. Okay, is this better?
Yes, ma'am. Thank you.
Okay, thank you. Yeah, absolutely. So when we think about ECT, we think about, the concept is very simple. There is a very small electric pulse that is being passed through the brain, and it's like sending a reset signal to the brain where you are, restoring the neurotransmitters in the brain. You also kind of helping with the brain-derived neurogrowth factors, protein synthesis. And patients typically start responding after the 5th or 6th treatment. Typically, psychotic patients patients with catatonia start to make dramatic and remarkable improvements after the 5th treatment, and those with depression after the 6th or 7th treatment. Next slide, please. Okay. So these are some numbers just to kind of give you an idea. So the response rates for ECT can vary anywhere from 50 to 86%. And I just want you to think about, the treatment population that we are dealing with here. These are patients who have been through several antidepressant trials where the remission rates with every medication trial is in the teens, either somewhere between 10 to 50%, 15%. So for such patients, we're talking about response rates 50 to 80%. So that is something that we have to factor in when we look at the numbers. So, out of all the patients that you are treating this, you're offering this treatment, about 85% of them are going to respond if you have had an inadequate medication trial, or if you've been through many medication trials where you have treatment resistance and your response rate can drop. That would go up to 50%. Next slide, please. Okay, yeah. So this is just talking about the earlier slide. You think about the STAR*D trial, we're talking about, these are patients with very poor response rates, 18 to 10%. And with ECT, that response rates can go climbing up to 50 to 80%. So the take home point is, if you have more trials failed, and these patients were really struggling, and ET should be considered a treatment option. Next slide, please. So let's talk about adverse effects, which are the most feared when it comes to ECT. One is, what is the most serious side effect that we can think about? And these are typically from risk from anesthesia. So if you don't have adequate anesthesia, muscle relaxation, then patients can have fractures. Some patients, if you're not well equipped, the seizures that you're doing, you just want it for 30 to 90 seconds. If they go on beyond 3 minutes, they can there's a higher risk of going into status epilepticus. You can have risk from, if there's not proper anesthesia screening done, then patients can be at a higher risk for cardiac events during the ECT. So every patient who goes through ECT has a medical clearance. If the internal medicine doctor feels the patient needs special oversight by cardiology or some other specialty, that's always completed. There are 2 physicians who are consenting to the treatment besides the patient, and there's always lab work and physical that is accompanied, and there is an anesthesia clearance. So there are lots of steps involved before a patient is cleared for ECT treatments. And it requires a really concerted effort with the medical team that we work with, because ECTs at Baptist are done in the surgical space of the Baptist Medical Center downtown, which is in the recovery area. And that is one of the safest places to get the treatment, because the nurses who are taking care, besides the ECT coordinator, who's also a nurse, are the medical surgical nurses who've been doing this for years. So talking about a few other less serious side effects, you can have muscle aches, body aches, nausea. You can have, soon after the ECT, you can have some agitation and confusion. Often these are very limited. They can go, body aches and headaches, they can be treated with either Tylenol or ibuprofen. And these are all very, short-lived side effects, and patients typically recover pretty nicely. And the most feared side effect from ECT is, of course, the cognitive impairment. Next slide, please. Okay, next slide, please. Okay, there we go. Yeah. So let's spend a minute or so on ECT amnesia. So when we think about memory loss, we're thinking about memory loss for anterograde or retrograde. Anterograde amnesia is where you're not able to form new memories. But what is, what we commonly find in clinical practice and what is also found in research, this is usually restricted to the period immediately following the ECT. So you may have some minor gaps in memory for, while you're just before the treatment or right after the treatment, but it's typically mild and it is limited. Sometimes we do find that what patients do have in past papers is that you can have retrograde amnesia, which is memories that have been laid before. So for any patient who, unless there's an absolute indication for bilateral ECT, there's enough and more evidence to show that one-sided ECT will be just as effective. So we want to minimize cognitive impairment, space out the treatments using unilateral versus lateral, make sure we use the lowest titrated electricals needed to induce a seizure. All go a long way in minimizing ECT amnesia. Slide, please.
Yes, I will advance, Dr. Pattaya. I don't know if there's an area where you are that maybe has a little bit better service. We're still getting a little bit of distortion in your voice, so apologies about that.
Oh, really? Okay. Okay. It's any better?
Okay. Are you with us? And you're connected to Wi-Fi, Dr. Pattaya?
Yeah.
Okay. Appreciate everyone's patience. This is the virtual world, isn't it? So sorry about this minor delay. Yes, Frida, we are working on a little bit of a connectivity issue. Go ahead, Dr. Pattaya.
Okay, can you hear me now?
Yes.
Okay. I am not able to see your slide. Okay, there we go. Okay, all right. Can you hear me better?
Yes, it seems to be clear at this moment. Thank you.
Okay, thank you. I appreciate it. Sorry about that. So I just want to say that ECT is typically a well-tolerated and safe treatment option. What I often do encounter is that when patients' severe depression has lifted, that their memory often appears to have improved. So they're able to be there more in the moment. They're able to register events and they're able to recall. So in fact, memory seems to have improved for a lot of patients that we treat who are in severe depressive episodes. Next slide, please. Okay, so I want to just spend a minute on frequency of ECT. In the United States, we do ECT as a standard 3 times a week, and it's typically Monday, Wednesday, and Friday. In Europe, it's done twice a week. And there have been rare occasions where we've had to do ECT almost on a daily basis if there is like a catatonia where the patient is rigid and they are extremely medically ill in ICU settings. So these are rare occasions where we have to do life-saving ECT options, and they can be remarkably they can be amazing interventions in restoring patients' lives. And we've had I've had personal encounters of where we've had to do daily ECTs, and it's been amazing to see the results. Next slide, please. Okay, so again, what we have noticed is ultimately the outcome when we are thinking about 3 times versus 2 times, the ultimate outcome is often the same, but the rate at which the recovery happens is much faster with the 3 times ECT compared to the twice weekly. Again, if you are doing more of the treatments, obviously there's more of cognitive impairment can be associated. But this usually, as I stated earlier, it is short limit, it is limiting, and it's not something long term. Next slide, please. Okay. So again, the number of ECTs vary on the treatment condition, treating
Dr. Pattaya, you may need to move around again.
We're losing you. Dr. Pattaya?
She's there.
So apologies all for the connectivity issues. Hopefully Dr. Pattaya is able to, I think she had to jump off and then rejoin us. But if you would just take a moment since we're waiting. Oh, here she comes. If you have any other questions that have come up, please do put those in the chat. Hey, Dr. Pattaya.
Okay. Oh my goodness, I'm so sorry. Is this okay?
Yeah,
Okay.
yeah. Can
Okay.
you see the
All right.
slides?
Okay, yes, I
Okay.
certainly can. Thank
Wonderful.
you. Okay. So want to quickly talk about, the number needed for ECTs. It varies between 6 and 12, and the goal is remission, where patients are completely free of their symptoms. And it is possible that they no longer have symptoms of depression or psychosis or catatonia. So it is remarkable to see the improvements from this intervention. Next slide, please. Okay. So, one of the things that I do want to say is that usually for patients with, the usual number that we don't exceed is about 15 or 18 ECT treatments. We do need, some patients with really severe persistent illness may need more than 20, but that is extremely rare. Most patients finish their acute treatment by 6 or after the 12 to 13 treatment. Next slide, please. Okay, so what the relapse following ECT is a major clinical problem, and what we have found is that about 80% relapse after within the first 4 months. So it's really important to continue with medications at the same time and to have continued follow-up. And what is recommended after the acute series is maintenance ECT, where there is a tapering series of ECT treatments. There is a continuation ECT and maintenance ECT. So there is a tapering of the ECT treatments where you get the treatment instead of 3 times a week, once a week for about 3 to 4 sessions, and you go down all the way to once every 4 to 6 weeks. And ultimately there is, we conclude the treatments. Very rarely do we need maintenance treatments beyond 6 months. Next slide, please. Okay. So this slide lists some risk factors for relapse. if you have had incomplete remission, if you still have some residual symptoms, if there is past history of high medication resistance or psychotic depression, unfortunately, younger age group, if you've had multiple prior episodes, medical comorbidity, poor social support, all of these are risk factors for a relapse. Next slide, please. Okay, so continuation therapy is ECT is where you can, as I described earlier, you have a tapering number of ECTs after the index treatment, and maintenance is if it's beyond 6 months. Next slide, please. So, you know, there has to be a gradual taper of the treatments, and because and this is a very clinically driven decision at some point. There is a rough guideline, but ultimately we have to see how is the patient doing clinically, how severe is it, and also depends on patient preference and compliance, if they have a ride and if they can make it, and if they're from town or out of town. There are lots of factors that we have to factor in. Next slide, please. Okay, and the most important thing that we always do is to look for, you know, is to assess one's cognition. So for all patients who are entering the treatment, we always measure their cognitive, we always get a baseline of their cognitive function by doing some standard bedside tests before the treatment, during the treatment, and after. Next slide, please. Okay, again, these are some standard requirements that just talk about, you know, these are very specialized treatments. We have to have the patient's consent, you know, updated every 3 to 6 months. Next slide, please. Okay, and maintenance treatment, we currently do not have anyone in maintenance treatment where you have ECTs continued beyond 6 months, but in the past, I have encountered certain patients who have met the criteria, and typically if you have a strong history of recurrent illness, and if your symptoms return quite severely once you stop the treatments, and you know, for such patients, we do have to consider maintenance treatment. Again, it's a lot of this is also driven by the clinical judgment and patient preference. Next slide, please. This just talks about, you know, some innovative ways of doing maintenance treatment. Sometimes we've had ECT during the most vulnerable periods. Say if it is a seasonal recurrence of your mood disorder, then we can just kind of target the treatment right at that time. And again, we would be doing the exact same thing as for the index treatment. We want to do the minimum treatment required to obtain remission from symptoms. And there is no evidence of a lifetime maximum. And we, you know, the treatment plan needs constant updating. Next slide, please. Okay, so moving on to the third modality of treatment, which is Spravato. Spravato is esketamine. It is an antagonist of the NMDA receptors. And what it does is it modulates the neurotransmitter glutamate. So esketamine is, you know, one of the two molecules which are identical in their chemical composition, but they're mirror images. So esketamine is the version that the FDA has approved. The R-ketamine is the one that is available as an IV infusion, which is not FDA approved. It's an off-label use for depression. Next slide, please. So what is shown is that the esketamine has a higher affinity compared to the R-ketamine. And what it can do is it basically, again, it works on neuronal connections. It improves structural connectivity in the brain. It works on brain-derived neurofactors. Next slide, please. Okay, so currently the FDA approval is for not as monotherapy, but in conjunction with an oral antidepressant. And again, this is indicated for treatment-resistant depression, where you've failed 2 or more antidepressants, then you can, this is definitely something for you to consider. Also, if you have if you fail 2 or more antidepressant, but you have suicidal ideation, that would also be an indication for Spravato. Next slide, please. Again, as I said, it's not a monotherapy and it's only used for adults at this time. We do get referrals for teenagers and, below the age of 18. At this point in time, it's only approved for adults. Next slide, please. Okay, so this is just a box warning. Now, this is a medication which is a controlled substance. It is being monitored by the FDA through their REMS program. Next slide, please. I want to talk about it. Okay, so the REMS program is basically your risk evaluation and mitigation strategy program. So essentially, anytime you prescribe a patient the esketamine nasal spray, it is only available via prescription, and every time you have to be enrolled in the REMS program because we have to monitor for any kind of serious adverse reactions that can occur. The most commonly patients experience they feel they get sleepy. They're monitored for at least 2 hours after the nasal spray in the clinic by a trained clinician, a nurse or a physician or a nurse practitioner who is present during the whole administration. And their vitals are being checked at regular intervals, ensuring that they're safe and they're fine. And there's always somebody that knows the patient who's there to pick up and take them home. Next slide, please. Okay, so the dosage esketamine is intended to be, like I said, intended to be given in conjunction to an oral antidepressant. It's for nasal use only, and each nasal spray device delivers 2 sprays, a total of 28 milligrams of esketamine. And we use 2 dose devices for a 56 milligram dose, or three devices for an 84 milligram dose. And the dosages are either 56 or 84 milligrams with 5-minute rest in between use of each device. Next slide, please. Okay, so there is something called as an induction phase and a maintenance phase. The induction phase is for the first month, where you're administering the medication twice per week. And the starting dose is always the lower dose, which is the 56, and the subsequent doses can be either 56 or 84, depending on the tolerance. And then there is a maintenance phase where you have between for the second month, you're administering once weekly at either 56 or 84, and after which it's every 2 weeks or once weekly, depending on how the patients are doing and also the tolerance. Next paragraph. Next slide, please. Okay. The most common side effects would be, dizziness, nausea, sedation, vertigo. We always have to, if you have uncontrolled hypertension, we always want to make sure that you have a clearance from your physician, or your hypertension is adequately controlled before the medication can be even approved. Next slide, please. Okay, so I do want to, spend just a minute to talk about how well it works. Can we skip over the slide just in keeping everyone's time here? The next slide essentially captures. Okay, so what it's shown is that there is anywhere between 27 to 69% of the patients, that is about 1/3 to 2/3 of the patient, were responders. That is, they showed 50% or greater improvement in depression after 4 weeks of treatment. Think about, even though this is a small effect size, we have to think about the population and their response to typical antidepressants. Next slide, please. Okay. So again, if we were to compare, just look at the second point there, esketamine 56 milligrams for the new oral antidepressant, the response rate is 10%. And with the 84 milligram, it's about 9%. So it's similar. But if it is a placebo, it's about 2%. So there is a statistically significant difference, 7 to 8% between the two, which is quite impressive. Next slide, please. Okay, and patients start noticing that even after 24 hours of taking the esketamine, there is a very significant change in their mood, and which kind of sustains over 4 weeks, especially when coupled with antidepressants. Next slide, please. Okay, just to quickly wrap up, it is self-administered. So it is obtained from a special pharmacy. There is a nurse who is present when you are administering the medication in the clinic, in a quiet, peaceful room, and then you're being monitored for at least 2 hours after the treatment, and then you go home with a friend or a loved one. Next slide, please. Okay, this is just to capture what we just said, the induction and the maintenance phase. Next slide, please. Okay. Lastly, I just want to touch upon the vagal nerve stimulation, which is neuromodulation. Think about it as pacemaker to the brain. Next slide, please. Okay, so essentially, if you have failed 4 or more antidepressant medications, or medications in general, whether it's unipolar or bipolar depression. As of July of 2005, the VNS is approved for such patients. You essentially you are planting this device that is wrapping around the 10th nerve, which is the vagal nerve, and this sends out electrical impulses that ultimately carrying impulses to the brainstem that kind of have widespread changes and improve depression. The novelty about the VNS is that these effects can last for as long as the device is in your system, and typically that is for about 7 years. So patients with severe treatment resistance who have completed ECT, who have had remission of symptoms for some time, who are still struggling, but have relapse of symptoms, can be great candidates for VNS treatment. Next slide, please. Okay, so just want to think about, at this point in time at Baptist, we are offering the first 3 options that we discussed, which is the TMS, so the transmagnetic stimulation, ECT, and Spravato. We are thinking about the VNS, which is the vagal nerve stimulation. And if you have anyone that you're interested in referring, then if you were to go to the orders and put in ambulatory referral to psychiatry and choose the option, then that would be a really good way. That would be a way to get your your referral into us. Next slide, please. Okay, this is just a quick, bullet point on the indications for Spravato and TMS. Again, you have to be 18 or older, diagnosis of major depression, and the number of antidepressants that you have failed. And again, the PHQ-9 is a rating scale for depression. Next slide, please. Okay, so some helpful links here. And again, the outpatient manager for the South Bank office, which is typically our referral phase, is Marcel Brown. And, we do have a lot of availability. So if you have any patients, anyone that you think would benefit from any of these treatment options, please don't hesitate to send those referrals over. Thank you.
Excellent. Thank you, Dr. Pataya. So we do have a few questions. So for all that have to leave at 1 o'clock, we understand, but if you can stay on, please feel free to stay for about five minutes. The first question, Dr. Pataya, would TMS be something considered as a first choice for more severe cases? Another person commented the swing in efficacy is, 10 to 80%. So why not incorporate the treatment earlier?
Oh, absolutely. The only thing is treatment. The major caveat is that TMS is an expensive treatment option, and it is covered by insurance companies. So, at this point in time, the insurance companies only authorize if you have completed several antidepressant trials, 2 or more. But occasionally I've had patients who do not want to go through insurance companies and want to be able to bear the costs. And, if there are no absolute contraindications, then I do not see why TMS should not be offered in the first place. At this point in time, it is offered as a second line agent to medications and psychotherapy and not as a first line.
Okay. So another person inquired, does a patient being on Klonopin for anxiety affect response for ECT due to anti-seizure activity?
Absolutely. So Klonopin, which is clonazepam, is a long-acting benzodiazepine. So if possible, switching to a shorter acting benzodiazepine like lorazepam would be helpful. And for all patients who are getting their treatment, we often ask them to not take any benzodiazepines after 6 p.m. the night before. So it's not an absolute stop. There is, switching to a shorter acting medication and not taking anything after 6 p.m. the night before would be really helpful.
And from our own Dr. Hirsch, will glutamate be the neurotransmitter of the 21st century?
Your guess is as good as mine. I think so. I think that the ketamines has just kind of paved the path to the next level, and I absolutely think that that would be the way to go.
Melissa asked, is ECT safe for pediatric patients? There is that criteria of 18 or above, but in your opinion?
So ECT can be safely administered for young patients. Again, lots more to consider and think about in this population if we have to go down the ECT route. I've had in my experience, the instances where we have offered patients ECT in the younger population is we've had an extremely severely autistic patient with severe outbursts and with bipolar disorder diagnosis, where nothing for months together with multiple back-to-back admissions was offered ECT, and that made a significant difference. There was also a pediatric patient, about 16-year-old, who came in with severe catatonia, and a $1 million workup came out to be negative, and ECT was helpful for that patient because he was not eating or drinking and he was just having failure to thrive. And we've also had patients with, there was another patient with partially responding catatonia where medications have not made lasting changes, and ECT was offered. Yes, so ECT can be offered to pediatric patients, but it has to be very carefully considered, and typically involves almost like double, triple the work than with adults. Lots of consenting that needs to happen with families. Has to be 2 child and adolescent psychiatrists who have to independently recommend ECT, and the families have to consent, and many, many steps involved.
Okay. Well, thank you so much for your time. We really appreciate it. Thank you everyone for joining us. We hope that you attend our next Grand Round series. If you do want a copy of the recording pending its availability, we can get that out to you. Email behavioralhealtheducation@bmcjax.com. And I can also share with Dr. Pataya's permission, of course, a PDF of these slides so that you have the information for future use. Thank you, everyone. Hope you have a great afternoon. Happy Friday, and see you next time.
Thank you so much.
Yeah. Bye-bye.